Now we have some of the commonly performed periodontal surgeries: phrenectomy and periodontal flap surgery.
Tongue tie or ankyloglossia is a developmental anomaly of the tongue characterized by an abnormally short, thick lingual frenum resulting in limitation of tongue movement. Lingual phrenectomy is advised for the management of ankyloglossia. The advent of lasers has undoubtedly made this procedure more comfortable for the patients with less postoperative complications. A 43-year-old patient reported to the Department of Periodontology with chief complaint of discomfort in tongue movement leading to difficulty in speech, difficulty in stretching his tongue completely outside the mouth, and difficulty in touching the palate with his tongue. On intraoral examination, short, thick lingual frenum was detected. After taking consent from patient, lingual frenectomy with diode laser under ALA was planned. After anesthetizing the lingual frenum locally, tongue traction was done with the help of a suture material. Diode laser beam was then applied lingually, both vertically and laterally to the frenum to disrupt the mucosal continuity. No postoperative sutures were given. Patient reported increase in tongue mobility following surgery. An extension of the tongue outside the mouth had increased from preoperative. Speech articulation had also improved after surgery, and patient was able to touch the palate with the tip of tongue, which improved phonetics.
Now let us learn conventional phrenectomy.
Frenum is a mucous membrane fold that attaches the lip and cheeks to the alveolar mucosa, gingiva, and underlying periosteum. Plasek et al. Has classified frenum into four types: mucosal, where the frenal fibers are attached to the mucogingival junction; gingival, where the fibers are attached within the attached gingiva; papillary, when fibers are extending into the interdental papilla; and papillary penetrating, when the frenal fibers cross the alveolar process and extend into the palatine papilla. A 13-year-old male patient presented with a chief complaint of spacing between the upper anterior teeth and was referred from the Department of Orthodontics for frenectomy. The frenectomy technique performed in this case was the conventional technique by Archer and Kruger. The area was anesthetized with local infiltration, following which the frenum was engaged with a hemostat inserted into the depths of the vestibule. Incision with number 15 scalpel blade was placed on the upper and lower surfaces of the hemostat until the hemostat was free. The resected portion of frenum with hemostat was removed, leaving a rhomboid area exposing the deeper connective tissue fibers. Dissection of muscle fibers was done on the bone, and the resultant wound was sutured with simple interrupted sutures.
Now we
Filler
have
incision was
periodontal
given by
flap
using
surgery.
number 15 blade. The blade was directed from the gingival sulcus towards the alveolar bone crest. Next, full thickness mucoperiosteal flap was reflected by using a periosteal elevator. The flap was reflected by taking a support from the underlying bone. A thorough debridement of the granulation tissue was done under continuous irrigation of saline by using curettes, and also a residual calculus deposit was removed by using scaler. Mersilk 40 suture was used for the flap closure. First, the suture needle was inserted through the buccal flap at the base of the papilla. And it was taken out from the same side of the incision. Next, the suture needle was inserted into the palatal flap, directing it towards the buccal flap. And then the knot was tied on the buccal side of the flap. At last, periodontal dressing was placed on both buccal and palatal aspects of the flap.
A clavicular incision is given by using a number 15 blade. The blade was directed from gingival sulcus towards the alveolar bone crest. A full thickness mucoperiosteal flap is reflected by using periosteal elevator, and thorough debridement of granulation tissue was done using curettes, and residual calculus deposits were removed using scaler. Depth of the defect was measured, which revealed that it was a shallow two-walled defect. Periochole barrier membrane was cut into an appropriate shape and placed over the bone. Next, the osteograft bone graft material was used to fill the intra-bony defect, and membrane was approximated over it prior to suturing. Vertical mattress suture was given at the site of bone defect, followed by indirect interrupted suture. Copac was used as the periodontal dressing and was placed over the buccal as well as the lingual flaps.
This is a case of a patient of plasma cell gingivitis showing gingival overgrowth. We mark the incision line to be carried out with the help of an hematoxylin pencil so as to determine the area of excision. It is done with the help of determining the pocket depth with the help of a probe and pocket marker as well. Incision is carried out with the help of an external bevel gingivectomy wherein the blade is held at a 45-degree angle towards the tooth surface and the tissue is excised. The excised tissue, and this is the post-op photograph.